our guest speaker is Dr. Meera Mohan from Wisconsin. She will be lecturing on incorporating bispecific antibodies into the management of relapsed refractory multiple myeloma. This webinar, as usual, is brought to you by Mumbai Hematology Group. It is supported by Johnson & Johnson, Natco Oncology, Lucian Life Sciences, and Nirvin Life Sciences. It's managed by Perfect Square. I'm thankful to Team Johnson & Johnson, Natco, Lucian, and Nirvin, Mr. Yash, Mr. Kalpesh, and Team Perfect Square, Executive Committee of Mumbai Hematology Group, our guest speaker, Dr. Meera Mohan, all our discussants who are themselves eminent hematologists or medical oncologists, and all of you who have registered and participating today as discussants or observers for sparing your Saturday evening if you are from India, and maybe morning or afternoon from the rest of the world. Tomorrow morning, that is Sunday, 6th April, at 11:30 a.m. IST and the Italian time 8 a.m., we have Dr. Maria Capellini speaking to us on problems of thalassemia beyond the age of 30 years. Our discussants include Dr. Amit Khurana, Surat, Dr. Ankur Ahuja, Pune, Dr. Ashwin Nair, Trivandrum, Dr. Babita Sodhi, Delhi, Dr. Bhavani Mandawa, Bhubaneswar, Dr. Divya Manohar, Chennai, Dr. Gopinathan, Chennai, Dr. Hita Kalikat, Dr. Hartik, Chennai, Dr. Kishore Kumar, Chennai, Dr. Kunal Goyal, Mumbai, Dr. Manasa, Guwahati, Dr. Manoj Unni, Kochi, Dr. Mayur from Ahmedabad, Dr. Nikul Tikare from Delhi, Dr. Nikhil Haridas from Kochi, Dr. Nithya from Chennai, Dr. Prasanna from Tiruchirappalli, Dr. Raghuvir Prabhu Kalikat, Dr. Rakesh Kochi, Dr. Sandeep Patnaik Kochi, Dr. Shilpa Gupta Mumbai, Dr. Shrikant Chennai, Dr. Steve Thomas Chennai, Dr. Sugit Trivandrum, Dr. Sushma Bangalore, Dr. Thila Gavathi Venkatesan, and Dr. Thomas Kucheria from Kochi. Dr. Meera Mohan does not require an introduction to you, especially on the subject that you're going to hear her from. Just to complete the formality, she's Assistant Professor, Division of Hematology Oncology, at Department of Medicine, Medical School of Wisconsin at Wisconsin, US. She holds the position of Assistant Professor within the Division of Hematology Oncology. She is specialized in bone marrow transplantation and cellular therapies at the Medical College of Wisconsin. Her educational journey commenced at the Kerala Medical University in India, where she completed her medical school training. Subsequently, she pursued her residency at Wayne State University, followed by a clinical fellowship at the University of Arkansas, where she also served as Chief Fellow. Currently, her clinical and research focus is plasma cell dyscrasia. She serves as the principal investigator of several clinical trials for patients with multiple myeloma. She has co-authored and authored close to 100 peer-reviewed publications in her short career thus far, and is the recipient of KL2 Career Development Award for her work on MRD in myeloma. As stated earlier, she will be lecturing on incorporating the bispecific antibodies into the management of relapsed refractory myeloma, a subject which is very close to her heart. I'll stop here and request her to take over.
Good evening. Thank you, Dr. Agarwal, for the kind introduction and the invite. So I'm hoping to provide a very pragmatic overview of bispecific antibodies for use in multiple myeloma. Let's see. So these are my disclosures. So bispecific antibodies in myeloma, as we all know, are synthetic antibodies that bind to an immune effector cell and a target antigen of interest on the myeloma cell. So in this case, the immune effector cell is a T cell, and it can target different antigens on the myeloma cell, including BCMA, GPRC5D, FCRH5, etc. We currently have 3 FDA-approved products. Teclistamab and elranatamab are directed against BCMA on the myeloma cell, and talquetamab is directed against GPRC5D on the myeloma cell. So as shown here in the figure, pretty much what it does is these bispecific antibodies bring in the T cells in close proximity to the myeloma cell and promote eradication of the tumor by T cell mediated cytotoxicity. I also want to highlight here one of the ASH educational chapter written by Dr. Holly He. It was actually from ASH of 2023. It gives a very good overview of bispecific antibodies for use in multiple myeloma. So we have several bispecific antibodies that are currently investigational. So some of them are directed against BCMA and other targets, non-BCMA targets like GPRC5D, FCRH5, CD38, etc. I want to highlight some of the select investigational bispecific antibodies here. Linvoseltamab here is a fully human antibody directed against BCMA. So it is distinct from teclistamab, elranatamab in being fully human. It also has a very favorable every 4-weekly dosing after the initial ramp-up dosing, that's after the first 6 months. And we do anticipate linvoseltamab will be available and FDA approved for use in the summer of this year. So bispecific antibodies, they differ in their structure. So I want to highlight some of the bispecific antibodies with unique structures here. So alnuctamab and forimtamig has a unique 2:1 configuration. So the idea here is that they have a bivalent target binding domain. This is supposed to enhance the efficacy. Alnuctamab is directed against BCMA, and forimtamig is a 2:1 bispecific antibody directed against GPRC5D. Another unique bispecific antibody that's also investigational at this point is etentamig, or the ABBV383 product, as shown here in the figure. Here. I'm sorry, is the slides advancing?
No.
Yeah, I think I have an issue here. Should I stop sharing and do it one more time? Let's see. Okay. All right, from the beginning. Okay. Sorry for the technical glitches here. I've just tried one more time. Let's see. From the beginning. Can you all see the screen or?
Yeah.
Okay. Maybe I apologize again. So I'll go back to. So this is actually the slide where we were discussing.
Yeah,
previously. So linvoseltamab, as I was alluding to, is a BCMA-directed bispecific antibody. It's a fully human bispecific antibody, and it has a favorable dosing schedule where it will go to every 4-weekly dosing schedule after the first 6 months. And we do anticipate linvoseltamab will be approved for use in the clinic in the summer of this year. Bispecific antibodies also differ in their structure, as I was alluding to. So alnuctamab and forimtamig has a 2:1 configuration. The idea here is that they will bind to the 2 antigens simultaneously, thus enhancing the efficacy. Alnuctamab is directed against BCMA, but forimtamig is directed against GPRC5D. I also want to highlight here etentamig, which is one of the BCMA binding bispecific antibody. It has a unique bivalent BCMA binding domain, as shown in the figure here. But then uniquely, it also loosely binds to the CD3 on the T cells. So the idea here is to enhance the efficacy by the bivalent BCMA binding domain. At the same time, perhaps improve on the safety by reducing the incidence of CRS by the loosely binding CD3 domain. So I want to briefly go over the clinical trials that led to the approval of bispecific antibody. So teclistamab, as we all know here, is a first-in-class BCMA-directed bispecific antibody. This was approved for use in the US in October of 2023, following the results of the MajesTEC-1 study. So this is an early phase study that enrolled patients with heavily pretreated multiple myeloma. As shown here, the median number of prior lines of therapy was 5. 78% of patients had triple class refractory disease, and a third of the patients had pentaclass refractory myeloma. In the study, the dosing schedule is as shown here. There's an initial ramp-up dosing whereby the patients get the first dose of 0.6 milligram per kg, followed by 0.3 milligram per kg. And then after the initial step-up dosing, the dosing goes to 1.5 milligram once weekly until disease progression. So with all the bispecific that we are going to discuss today, there is an initial step-up dosing. The idea here is to slowly prime the immune system so as to avoid overt activation of the immune system and control the CRS and ICANS, etc. The exception here is etentamig, which I'll go through also in the subsequent slides. In 2024, the FDA modified the dosing schedule whereby patients who attain a complete response that lasted for about 6 months, we have the option of going to 1.5 milligram every other week. In this heavily pretreated patient population, teclistamab monotherapy was able to induce an overall response rate of 63% with VGPR or better attained in nearly 60% of patients. The median progression-free survival was over a year in this heavily pretreated patient population. The teclistamab is a drug with high clinical efficacy for use in relapsed refractory multiple myeloma, and we use it in the 5th line currently in the clinic. Elranatamab is another BCMA-directed bispecific antibody. The approval was also based upon this early phase clinical trial, the magnetism-3 study. The study, typical of early phase studies, also enrolled a heavily pretreated patient population. The median number of prior lines of therapy was 5. Here, nearly all patients had triple class refractory disease, and 70% of patients had were pentaclass exposed, and nearly half of the patients had pentaclass refractory disease. So the dosing schedule of elranatamab is slightly different from teclistamab. There's an initial step-up priming dose followed by the 76 milligrams flat dose administered once a week, cycles 1 through 6. And in patients who are able to attain a partial response or better that lasted for at least 2 months, we are able to switch to every other week dosing, cycle 7 and beyond. The overall response rate is pretty similar to what we have seen with teclistamab at 61%, with VGPR or better attained in 56% of patients. Certain subgroups of patients derived less benefit, such as patients with high-risk cytogenetics, as shown here, patients with high tumor burden with a bone marrow plasmacytosis of more than 50%, as well as advanced RISS stage 3 disease, as shown here in the forest plot. The median progression-free survival was about 17 months in this early phase study. So we also have elranatamab approved for use in the 5th line in the United States with patients with relapsed refractory multiple myeloma. So linvoseltamab is an investigational BCMA-directed bispecific antibody. We do anticipate approval of this drug in the summer of this year. So what's unique about this drug is it's a fully human antibody. The other unique feature is the less frequent dosing. As shown here in the figure, after the first 6 months, we could go to every 4 weekly dosing in patients who attained a VGPR or better. The overall response rate, as shown here at the 200 milligram, which is the active dose, is about 71%, with VGPR or better attained in more than 50% of patients. Here, the 18-month progression-free survival was nearly 60%. So this is also a highly efficacious drug. However, this drug is given intravenously, while teclistamab and elranatamab is administered subcutaneously. So we'll have to see how the uptake of this drug will be once it's FDA approved, because we already have 2 FDA approved drugs that are currently used in the clinic. So I want to highlight this particular drug. This is called etentamic, or the ABBV383. This is an investigational bispecific, but it has some unique features, as I had alluded to before. So it has a bivalent BCMA binding domain. The idea here is that this enhanced binding may improve on the efficacy, and then it loosely binds to the CD3. And the idea here is this might reduce the incidence of cytokine release syndrome. So this is a unique drug in the sense that it does not require an initial step-up dosing. So this is something that is, once approved, will be really favorable, especially for our patients who will have to stay close to our facility once during the step-up dosing. And if they were to be admitted, the median duration of inpatient stay for step-up dosing is about 10 days. The overall response rate here is pretty consistent at the high dose of 60 milligram every 3 weekly. It's about 60%, with VGPR or better attained in upwards of 50% of patients. So coming back to talquetamab. So talquetamab is a GPRC5D directed bispecific antibody. This is also approved for use in the clinic in the 5th line in patients with relapsed refractory multiple myeloma. Shown here are the results of the monumental study. So this study also enrolled a heavily pretreated patient population with a median of 5 to 6 prior lines of therapy. 80% of patients had triple class refractory disease, and a third of the patients had pentaclass refractory myeloma. In this early phase study, there were 2 doses that were identified: talquetamab at the 0.4 milligram administered once a week, and talquetamab at 0.8 milligram per kg administered every other week. Shown here is the efficacy data. The overall response rate ranged from 70 to 74% across these active doses. And we also have the progression-free survival as reported here. It's slightly better at the 0.8 milligram per kg subcutaneous dose administered every other week at about 11 months. And it's about 7.5 months in the group that got the 0.4 milligram per kg once weekly. And indeed, the dose that we commonly use in the clinic is a 0.8 milligram administered every other week. It's mainly for convenience for our patients because it'll be easy for them to make an every other week visit to the clinic. I also want to just briefly touch on some of the non-BCMA investigational bispecific antibody therapy. So forintamig, as I'd mentioned before, is a GPRC5D directed bispecific antibody. What's unique about this drug is it has a 2:1 configuration. It binds to two GPRC5D antigens on the myeloma cell simultaneously. So this is again an early phase study that enrolled patients with heavily pretreated multiple myeloma. What's unique about this drug is currently the clinical trial investigates a limited duration therapy whereby patients get doses at the dose is not clear, but the schedule is every other week dosing for a finite duration of 1 year. Cevostamab is another investigational bispecific antibody directed against FcRH5. And again, what's unique about the KAMA-2 clinical trial is that it is investigating a finite duration of therapy. So after the initial step-up dosing, the patients will be dosed at every 3 weeks for about 17 cycles. That's about 12 months. The overall response rate in this heavily pretreated patient population, pretty consistent, 57% with VGPR or better attained in nearly a third of the patients. So I want to briefly go over disease resistance to bispecific antibody. So we know that resistance and longevity of response is an ongoing challenge with use of bispecific antibody therapy in the clinic. So I want to broadly divide the mechanism of disease resistance into T-cell dysfunction mediated tumor intrinsic factors and tumor microenvironmental factors. So we know that similar to CAR T-cell therapy, T-cell exhaustion is a major mechanism of disease resistance to bispecific antibodies. So how can we improve on it? We really need fixed duration bispecific antibody to potentially help with T-cell exhaustion and improve the side effect profile and improve quality of life for our patients. And we have seen that bispecific antibody are currently investigated in combination with other myeloma drugs such as immunomodulatory agents, cell mods, checkpoint inhibitors. And in fact, they're also investigated in combination with other bispecific antibody that targets alternative antigens. We've seen in the early clinical trials that certain subsets of patients, that is patients with high tumor burden with a bone marrow plasmacytosis of 50 to 60%, patients with advanced RISS stage 3 disease, extramedullary disease tend to benefit less from bispecific antibody therapy, similar to what we have seen with CAR T-cell therapy. So what are some of the strategies that is being employed? Debulking prior to bispecific antibody therapy, either by using cytoxin-based chemotherapy or by local radiation, may help improve responses to bispecific antibody therapy. We've also seen recent publication in NEJM where they've used a combination of teclistamab and talquetamab for patients with relapsed refractory multiple myeloma. I'll be actually going through that data soon. So this study that used a combination of teclistamab and talquetamab were enriched in patients who had extramedullary disease, and we did see that this combination did have an higher overall response rate in patients who had extramedullary disease. I also want to highlight one of the important mechanism of disease resistance here. That's the soluble BCMA sink. So we know that BCMA is shed from the myeloma cell into the serum by the gamma secretase enzyme. So this soluble BCMA can bind to a BCMA-directed bispecific and interfere with the efficacy of this drug. So we have ongoing clinical trials that are investigating gamma secretase inhibitor in combination with BCMA-directed bispecific antibody to overcome the serum BCMA sink effect. This is again similar to what we have seen with the BCMA-directed CAR T-cell therapy. So this is another important question that's of interest to us. Do all patients on bispecific antibody therapy need continuous dosing? So this is one of the studies led by my colleague, Dr. Chakravarti. So what we did in the study was we identified patients who were treated on a bispecific antibody therapy, but then came off treatment for reasons other than disease progression and had at least a minimum of 3 months of remission of therapy. So by doing so, we actually identified 23 patients out of 250 patients who were treated with bispecific antibody therapy. So this is a heavily pretreated patient population with a median of 4 prior lines of therapy. And we see here that the median progression-free survival of therapy at 18 months was nearly 80%. So this study provides proof of concept that maybe not all patients need bispecific antibody therapy as a continuous dosing regimen. We actually build upon that data. This is actually unpublished data. So what we did was we now have a larger data set of patients, 720 patients who were treated with a bispecific antibody therapy. We used a similar definition, like a similar criteria where patients who got a brief course of bispecific antibody, but then came off treatment for reasons other than disease progression and were able to maintain a sustained remission for at least 3 months. So using this criteria, we identified 10% of patients, that's 68 patients. And not surprisingly, the most common cause of treatment discontinuation was infection. The second most common was ectodermal toxicity that's exclusive to GPRC5D directed bispecific antibody. So the key patient characteristics here is this is a heavily pretreated patient population, median of 4 prior lines of therapy. The median age was 70. Majority of patients received a BCMA-directed bispecific, which is the most common class of bispecific that we currently use in the clinic. So we found here that the 36-month relapse-free survival of therapy was 53%. And importantly, we also show that the hazard for first high-grade infection actually goes down with time away from therapy. The other important predictors of response of therapy in the study were attaining a complete remission and getting fewer prior lines of therapies. That is, patients who've got more than 6 prior lines of therapy did have a shorter relapse-free survival of treatment. So this is an important strategy actually that needs to be further investigated prospectively. So coming to extramedullary disease and bispecific antibody therapy. So I want to show this data that was recently published in Blood in 2024. So in this study, they actually did spatial transcriptomic analysis of extramedullary tissue. And they interestingly show that there's significant genomic heterogeneity in the extramedullary tissue. The expression of the antigens are really heterogeneous at this point. And we also see that the infiltration of the active T cells were confined to niches away from the myeloma cells. So what can we do to improve on the responses that we have seen with patients with extramedullary disease, especially when they're treated with monotherapy of bispecific antibody? So the redirect one study was recently published in the New England Journal of Medicine, where they investigated combination of talquetamab and teclistamab in patients with relapsed refractory multiple myeloma. So this study included 94 patients, heavily pretreated multiple myeloma with a median of 4 prior lines of therapy. So here they've enriched for patients who've had extramedullary disease. 36% of patients in the study had extramedullary disease. The overall response rate at the RP2R was 80%, with complete response or better attained in 52%. Here, the overall response rate in patients with extramedullary disease was nearly 60%. So it's much higher than what we have seen with talquetamab or teclistamab used as monotherapy. The 12-month progression-free survival at the RP2D dose was 74%, and the 12-month progression-free survival in patients who had extramedullary disease was 53%. So this is a very promising approach, especially in select patients with high-risk myeloma, particularly extramedullary disease. I also want to highlight here the safety concerns with using teclistamab and talquetamab in combination. The incidence of high-grade infection was nearly 90%. Grade 3-4 infection was seen in 64% of patients. An opportunistic infection actually occurred in 10 patients in this study. And 11 out of the 14 deaths that were reported in this study was linked to an infectious complication. So this really highlights that a combination therapy may not be the right approach for every patient, but in select patients with extramedullary disease, this can be used, but then we have to be extra cautious. Patients should be on adequate infection mitigation strategies. So I want to summarize the T-cell therapies that we have available for use in relapsed refractory multiple myeloma. So we have 2 FDA-approved CAR T-cell therapy, ide-cel and cilta-cel. So ide-cel was approved for use in the 5th line in 2021, following the results of the phase 3 KarMMa-4 study. We have approval for use in the 3rd line. Cilta-cel was approved for use in the 5th line following the CARTITUDE-1 study, and following the results of the CARTITUDE-4 study, it's currently approved for use in the 2nd line in relapsed refractory multiple myeloma. We have 3 FDA-approved bispecific antibody, teclistamab, talquetamab, and elranatamab. Teclistamab is directed against BCMA, talquetamab is a GPRC5D directed bispecific, and elranatamab is a BCMA directed bispecific. And all of these drugs are approved for use in the 5th line in patients with relapsed refractory multiple myeloma. So I want to highlight another common clinical conundrum that we face in the clinic. How do we sequence these novel therapies in multiple myeloma? So when we think about sequencing immunotherapy, we have to think in terms of sequencing different antigen and then sequencing different therapy. We know that when we sequence these T-cell therapy, the overall response rate and progression-free survival is much lower than what we see in the T-cell naive setting. So I just want to highlight 2 important considerations here. So when we try to sequence these drugs, we want to ensure a longer washout period between these therapies. And we know that T cell dysfunction is an important and perhaps the most common cause of disease resistance with both bispecific and CAR T cell therapy. Target antigen loss have also been described in the setting of both BCMA and GPRC5D directed CARs and bispecific antibody therapy. So we know that target antigen loss is a rare cause of disease resistance in patients who get a CAR T cell therapy, patients who get a BCMA CAR T cell therapy. So it's seen in about 5% of patients. However, in patients who get a BCMA-directed bispecific antibody therapy, target antigen loss is much more common. We could see target antigen loss in about 40% of patients. So this is something to keep in mind when we sequence these drugs. So the approach that we do in the clinic is I would prefer a BCMA CAR T cell therapy early, and then a BCMA or a GPRC5D directed bispecific when there is disease relapse following a BCMA CAR T cell therapy. I'm not going to talk about GPRC5D directed CAR because currently it's not available in the clinic. So this is the results of MajesTEC-1 cohort C. So this particular cohort allowed enrollment for patients who had a prior BCMA-directed therapy. So in this study, they investigated teclistamab in patients who've got a prior BCMA-directed therapy, and majority of patients in the study got a BCMA-directed antibody drug conjugate. So until recently, we did have an belantamab, which is a BCMA-directed antibody drug conjugate. It was FDA approved, but then it was withdrawn from the clinic because of negative results of phase 3 study. But we do anticipate that Blenrep or belantamab will be available in the clinic in the earlier lines following the positive results of in the earlier lines that we've seen. There were 2 NEJM publications on belantamab combinations in the earlier line. So coming back to the study, the cohort C of the MajesTEC-1 study, the overall response rate in all comers was 52%. We see here that the overall response rate was pretty consistent in patients who've got a prior antibody drug conjugate and a prior CAR T cell therapy. But then when we look at the progression-free survival in patients who've got teclistamab following a BCMA-directed CAR T cell therapy was about 4.4 months. And in patients who've got a prior BCMA-directed antibody drug conjugate, the numbers are a little more favorable at 7.3 months. Now coming to more of the practical aspects of giving bispecific antibody therapy, the toxicities and challenges with bispecific antibodies. So we know that these drugs are associated with novel toxicity. So similar to CAR T cell therapy, bispecific antibodies are also associated with the risk of CRS, ICANS. Most of the bispecific antibodies that are available currently, they have an initial step-up dosing to slowly prime the immune system so as to avoid uncontrolled inflammatory storms and cytokine release syndromes and ICANS, etc. So this is data from the pivotal clinical trials where we see that the incidence of CRS range anywhere from 57 to 76%. Unfortunately, most of these are low-grade events. We see here that grade 3 for CRS is really like negligible. It's like 1.5% with talquetamab, 0.6% with teclistamab, and it's actually 0 with elranatamab. The median time to onset is slightly different across these bispecific antibody therapy, and the median duration is about 2 days with these agents that are currently used in the clinic. The incidence of ICANS is also much lower than what we have seen with the CAR T cell therapy. All grade ICANS occur anywhere from 3 to 11% of patients, and they are mostly grade 1, 2. The time to onset of ICANS is also slightly different across these bispecifics, 2.5 days to 4 days. The median duration is about 2 to 3 days. I also want to highlight infection risks across these bispecific antibody. As expected with BCMA-directed bispecific antibody, the incidence of all-grade infection is much higher, 70 to 76%, with nearly half of them being grade 3, 4. However, with talquetamab, which is a GPRC5D-directed bispecific, the incidence of high-grade infection is much lower at 14 to 20%. So in this study, we actually compared the adverse effects of interest across the BCMA-directed T-cell therapy, CRS, ICANS, neurotoxicity, and infection. So we show here that the reporting odds ratio for infectious complication was highest with teclistamab therapy compared to ide-cel and cilta-cel. We also were interested in non-relapse mortality with the BCMA-directed T-cell therapy. In this study, ide-cel had the lowest odds ratio for non-relapse mortality, while teclistamab, as shown here, had the highest odds ratio for non-relapse mortality. The most common events associated with non-relapse mortality were also different across these products. With ide-cel and cilta-cel, is predominantly CAR complications such as CRS, ICANS, HLH, etc. With teclistamab, the leading cause of non-relapse mortality was infection, COVID-19 infection, sepsis, pneumonia, etc. I also want to take a little bit of time to go over the unique toxicities that we see with talquetamab in the clinic. So we know that GPRC5D is expressed on ectodermal tissue. So what is shown here is the on-target off-tumor effect with GPRC5D directed bispecific talquetamab. So this is a picture showing onychomedesis, which is pretty much separation of the nail from the nail bed. And this is pretty common. We see nail changes in anywhere between 60 to 70% of our patients treated with talquetamab therapy. And this is the skin toxicity that we see, palmoplantar where you're peeling of the palms and soles with talquetamab therapy. Fortunately, this is not painful, and our patients are able to continue therapy with dose modification and good supportive care measures. So how do we select a patient for bispecific antibody therapy when we have all these options in the clinic? So bispecific antibody therapy are off-the-shelf, readily available and scalable option for our patients with relapsed refractory multiple myeloma. So when we have a patient in the clinic who has rapid relapsing myeloma who needs treatment like tomorrow, this is where I choose bispecific antibody therapy. We know that with CAR T-cell therapy, we need anywhere between 4 to 8 weeks between the first time we see the patient in the clinic to the actual CAR T-cell infusion. And we've seen from the data that bispecific antibody definitely have a better safety profile with a lower incidence and severity of CRS and ICANS. So this could be a safer option for our frail and older adults with myeloma, where ICANS and CRS can really be debilitating. And when we choose one bispecific over another, I typically go over the distinct toxicities. For example, in a patient who's had issues with infection, opportunistic infections, etc., we should be cautious when we choose a BCMA-directed bispecific such as teclistamab and elranatamab. So in that circumstances, I would choose talquetamab. And in a patient who has, for example, cancer-induced cachexia, talquetamab therapy can be challenging because we know that it's associated with unique toxicities such as oral toxicity, weight loss, etc. So what are some of the challenges that we encounter with bispecific antibody therapy for myeloma? So currently, bispecific antibodies are given as a continuous dosing schedule, and we really need studies exploring finite duration therapy. We know that bispecific antibodies need an initial step-up dosing, and most of the places in the United States, they tend to admit patients for the initial step-up dosing, and this is really not a sustainable option, and we really need better outpatient strategies to ensure that we can do the step-up dosing safely as an outpatient for our patients. We've seen the risk of infection and infection-related mortality with bispecific antibody therapy. We really need effective infection mitigation strategies. Also, less frequent dosing and finite duration therapy may help further mitigate the risk of infection as shown before. And we also have the subset of patients who really don't derive a lot of benefit from bispecific antibody therapy. These are patients with extramedullary disease, high tumor burden, advanced RIS stage C disease. And it is in this patient population we really need combination therapy and perhaps use of bispecific antibodies in the earlier lines to improve outcomes. So I want to briefly go over the common dosing schedules that we use in the clinic. So this is the FDA-approved dosing schedule. That is, for teclistamab, we give it once weekly, and in patients who've attained a complete response that is lasting for about 6 months, we can go up to every other week dosing. With elranatamab, the dosing schedule is slightly different. We do once weekly dosing cycles 1 through 6, and in patients who've attained a partial response or better, there's the option of going to every other week, cycle 7 and beyond. With talquetamab, we can go to every other weekly dosing upfront. There is the option of doing weekly dosing as well. So we were interested in understanding that, what is the dosing schedule that's currently used in the real world setting. So we looked into this particular issue, and this is data from a real world registry of about 700 patients who were treated with teclistamab and talquetamab. So we see here that the dosing schedule becomes less frequent with time on therapy. So in the first 90 days, the most common dosing schedule is once weekly for teclistamab, as shown here in this kind of peachy shade. And after the first 3 months or so, the most frequent dosing schedule is still once weekly, but then about a third of the patients go to every other week dosing. And beyond 6 months, we see here that increasing number of patients are dosed every other week. Still about a third of the patients receive once weekly dosing. With talquetamab, however, the most frequent dosing from the get-go is every other week dosing, as actually shown with the yellow box plot here. And we've also seen some data on how a finite duration of therapy could be a feasible option, especially in a certain subgroup of patients. I want to go over some of the practical challenges with outpatient step-up dosing for teclistamab. So this is one of the approaches actually pioneered by the group in Emory, where they use tocilizumab prophylactically in patients treated with teclistamab. So what they do is they administer tocilizumab at a dose of 8 milligram per kg intravenously an hour before the step-up dosing. So initially they investigated TOSI before the first step-up dosing, and then they went to the second step-up dosing. And currently what I understand is they've gone to giving tocilizumab as standard of care 4 hours before the first step-up dosing. So nevertheless, the data is as shown here. With use of prophylactic tocilizumab, the incidence of CRS is much lower, 26% compared to 73% in patients who did not get prophylactic TOSI. And most of these cases are grade 1 CRS. The incidence of ICANS was also much lower, 5% in patients who got prophylactic TOSI and 20% in patients who did not receive prophylactic TOSI. And fortunately, all of this were grade 1. So use of prophylactic tocilizumab can maybe facilitate outpatient administration of teclistamab, and this is something that really needs further investigation. I want to highlight our approach here. We have an all-outpatient step-up dosing program for teclistamab without tocilizumab, and as you might know, we actually do all of our CAR T-cell therapy as an outpatient too. So the bispecific antibody program was actually kind of built on the CAR T-cell program. So shown here is an example of the treatment calendar for a patient who gets teclistamab with us. So the patients are seen every single day, day 1 through 13. So the first dose is given cycle 1, day 1 here, right here. So the first dose is actually 42% of the target dose. The patient will be seen in the clinic and will have a clinic visit. And then day 2, the patient will have a clinic visit, but then will be seen by one of our nurses in the clinic. And day 3 is when we will proceed with the second step-up dosing. And that day, the patient will have labs and will be seen in the clinic again. Day 4 will be an RN visit. And day 5 is where we will do the first, the third dose, whereby the patients will get labs and will also be seen by the MD in the clinic. And then we go on to a weekly dosing, where which is this is actually a rough estimate. It's usually anywhere between 12 to 14 days. So if the patient was to have CRS, let's say the patient has CRS right here, right? So the patient will call us. We do have a 24-hour clinic that is housed within the cancer center. The patient will call us. We will triage the patient, and the patients are usually advised to take dexamethasone. We do provide dexamethasone when we see them for their cycle 1, day 1 of therapy. This is dexamethasone that is not a pre-medication. So every patient who gets a bispecific antibody, they do get a pre-medication cocktail with Tylenol, Benadryl, and dexamethasone. And the dose of dexamethasone that we use for pre-medication is about 16 milligrams. But then for the CRS, we actually provide pills of dexamethasone anywhere between 8 to 12 milligrams. We give the patient a script for dexamethasone. When the patient calls us with CRS, the patients are triaged and they are advised to take dexamethasone. And if there is ongoing fever, we will see the patient in our 24-hour clinic. And typically we do administer tocilizumab for ongoing grade 1 CRS. And the patients are monitored for about 8 hours after tocilizumab. And if there is complete resolution of the fever, the patient is actually discharged back to the clinic without inpatient stay as such. The other important aspect here is that we don't let our patients drive through this period. So they will have to have a caregiver who's available and who stays with them for at least for the first 7 to 10 days. So coming to infections with bispecific antibody therapy for myeloma. So this is actually one of the editorials that we wrote with the IMAGE group in India. So I want to highlight some of the key features here. So infection remains a major concern with bispecific antibody therapy for myeloma. So it looks like from the current data that infection-related mortality may have improved over time, but the incidence of all grade and high grade infection still remains high. And this, there's no clear plateau in the incidence of infection as long as the patients remain on therapy. So we really need clinical prediction models that can help us identify patients who are at a high and a low risk of infection so that we can employ a risk-adapted approach. So coming to the risk of infection with bispecific antibody therapy. So we know that in general, the risk of infection with bispecific antibody therapy is much higher when we use a BCMA-directed bispecific antibody therapy compared to a GPRC5D-directed bispecific antibody therapy. So the cumulative risk of infection also persists as long as the patient remains on therapy. As shown here in the figure, there is no plateau in the incidence of all-grade and high-grade infection. And we know that patients treated with BCMA-directed bispecifics tend to have prolonged and profound hypogammaglobulinemia. So this is one of our studies where we show that you can see here that the IgA level kind of, bottoms out and remains so as long as the patient remains on therapy. With the IgG levels, they tend to bottom out, but then the patients are started on IVIG. So that's why we see an uptake in the levels. With IgM levels, it's similar to what we have seen with IgA. It tends to bottom out as long as the patient remains on therapy, and they tend to have sustained hypogammaglobulinemia while on therapy. So what is the most common type of infection that we see with bispecific antibody therapy? Bacterial infections are the predominant infection that we see with bispecific antibody therapy, followed by viral infections. Fortunately, fungal infections are rare. I also want to highlight that we have also seen opportunistic infections in patients who receive bispecific antibody therapy, such as salmonellosis, CMV viremia, adenovirus hepatitis, parvovirus infection, enterovirus colitis, JC virus, PJP pneumonia, aspergillus, toxo, etc. We've also had a patient who've had norovirus that had persisted for months and months. And we, in fact, had to stop therapy. We even did a stem cell boost in an effort to help the patient's immune system. But then the patient ultimately did not make it. Actually, he passed up, away with failure to thrive while in remission. So I just want to highlight how bispecific antibody therapies are really associated with all these infections. And these are really not the typical infections that we see in a patient with myeloma. These are kind of infections that we see in patients with advanced AIDS or patients who got an allogenic transplant. So we have to keep this in mind when we see patients who are on therapy, particularly the BCMA-directed bispecific antibodies. And this is another important question that we are often asked. What is the risk of infection with a BCMA CAR T cell therapy compared to a BCMA bispecific antibody? So this is actually data from the Memorial Sloan Kettering group, where they looked into the risk of infection with BCMA CARs and BCMA bispecifics. As shown here in the figure, the incidence of severe infection appears to be higher with BCMA bispecific, as shown in the green curve. However, this was not statistically significant. The incidence of grade 5 event, that is death related to an infection, was exclusively seen in patients treated with a BCMA bispecific compared to a BCMA CAR T cell therapy. They also showed that the proportion of hypogammaglobulinemia appears to be similar with BCMA bispecifics and CARs. However, the infection rate during the period of hypogammaglobulinemia was much more common with a BCMA bispecific compared to BCMA CAR T cell therapy. So this is data that I've already shown before, where infection is indeed the leading cause of mortality with bispecific antibody therapy. So these are actually early results from, actually this is unpublished data, where we looked into non-relapse mortality with BCMA bispecifics and BCMA CAR T cell therapy as reported in the early clinical trials. So shown here are results from the pivotal clinical trials of BCMA bispecifics. And we see here the non-relapse mortality range anywhere from 1 to 16%. And similar to CAR T cell therapy, infection and sepsis are the leading cause of non-relapse mortality in patients receiving BCMA-directed bispecifics. Here, actually, it appears as though the infection and non-relapse mortality is much higher with bispecific antibody therapy. However, this was not statistically significant. So my takeaway message is that infection is a leading cause of mortality with both CARs and bispecific antibody therapy, and it does appear that it's similar with both BCMA CAR and bispecific antibodies. So what are some of the factors associated with increased risk of infection in patients treated with bispecific antibody therapy for myeloma? So we know that BCMA-directed bispecific antibody are associated with a higher incidence of infection compared to GPRC5D-directed bispecifics. Combination therapy of bispecific antibody, such as bispecific with other myeloma drugs or bispecific with another bispecific, increases the risk of infection. We've also shown data where steroid therapy as well as use of tocilizumab also increases the risk of infection. We often see that patients who've had one infection while on therapy are at risk of subsequent infections. And I also want to highlight the CAR Hemtotox score here. So this is a scoring system that was developed by the German group. This was actually developed in the context of CD19 CAR T cell therapy, but it was subsequently validated with BCMA CAR as well as BCMA bispecifics. So we show in the study here that a high CAR Hemtotox score, that is a score of 2+, was associated with a higher incidence of infection in patients treated with a BCMA-directed bispecific. I also want to highlight here that this is really a very easy score to calculate in the clinic. This is based upon readily available laboratory data. So this CAR Hemtotox score uses hemoglobin, absolute neutrophil count, platelet count, CRP, and ferritin at day 1 of therapy. This is something that we can easily adapt in the clinic. So the only factor that was associated with reduced incidence of infection was use of IVIG prophylaxis. This is our data that we presented at ASH of last year, where we show that in patients who got a prophylactic IVIG, right? So this is actually the blue curve here. Use of prophylactic IVIG was associated with improvement in infection-free survival in patients who got a BCMA-directed bispecific antibody. And this is actually the first time that any group have shown that IVIG prophylaxis, which is really a simple thing to do in the clinic, was associated with infection-free survival. And as you see in the curves here, there isn't a plateau in the infection-free survival. The risk of infection persists even in the group that gets IVIG prophylaxis, suggesting that there are other factors contributing to infection, and this needs to be further investigated. I want to summarize the infection prophylactic strategies that we have available for use in relapsed refractory myeloma patients treated with bispecific antibody therapy. So this was actually from the ASCO book that we wrote in 2024. So I want to highlight here use of IVIG prophylaxis. So we recommend starting IVIG prophylaxis early on. We actually start our patients who are treated at our center at cycle 2, and we actually start them on IVIG prophylaxis irrespective of a prior history of infection and irrespective of the IgG levels. However, the consistent definition is all over the place. And at this point, we really don't know the optimal approach. But then what I would do in the clinic is really start them early on, especially with this data that I've just shown where IVIG prophylaxis was associated with improvement in infection-free survival. I also want to highlight here the use of PJP prophylaxis, because in our series, the patients who got PJP infection, although this was rare, were patients who were not on PJP prophylaxis. So at our center, it's a standard to be on PJP prophylaxis throughout the course of treatment. So in conclusion, bispecific antibody therapies have shown single-agent efficacy in relapsed refractory multiple myeloma, and they have been investigated in the earlier lines in combination with other myeloma drugs. There's clearly a signal for infection, including infection-related mortality in the early clinical trials of bispecific antibody. We know that choosing one agent over another is often nuanced, and we would typically take into account various patient disease and treatment-related characteristics when we choose one agent over the other. Sequencing T-cell therapy is really important, and this is going to be an increasing problem as we have CAR T-cell therapy approved in the earlier lines, and soon bispecific antibodies will also be approved in the earlier lines. I would like to thank our patients and family for their contribution to the progress of clinical and translational research. This is my team at MCW. These are my collaborators and funding source. Thank you for your attention. Be happy to take any questions.
Thank you, Dr. Meera. That was fantastic. You updated us on all aspects of bispecific right up to the day. It was wonderful listening to you. I will request the audience to start putting questions in the chat box. Meanwhile, those who are here, they can use the raise hand sign. And I'm going to start with the first question. Is there any situation where you give antifungal prophylaxis? Any situation?
So we have not used it as routine for our patients. So I can tell you in the context of CAR-T, I can tell you. So what we do is if any of our patients get at least, if they get more than one dose of TOSI, they were to be on anakinra, like if they get anakinra for CRS or whatever, HLH or whatever. So those are patients that I always start, antifungal prophylaxis right away, because I know that in these patients, we are going to have prolonged neutropenia as such. But then with bispecific antibodies, we don't see prolonged neutropenia, because maybe because we are very proactive. Like the moment the neutrophil count is anywhere, between 500 to 1,000, we have a low threshold to administering, growth factor support and etc. So not routinely for bispecific antibodies, but I have a low threshold for patients who are treated with CAR T-cell therapy for sure. Yeah. I hope it answered your question.
Yeah, sure. Thank you so much. Dr. Babita, your question.
Anji, first, thanks for having me, first of all, on this platform. Dr. Meera, what a lovely presentation, and you have covered everything. I don't think you have left anything, but we have learned a lot, and we have just revised so many things. But I have a very basic query that what is the exact definition of relapsed and what is the exact definition of the refractory? Are there any stringent criteria, any unanimous opinion which we can follow so that we can have the revolving axis that, yes.
So thank you. That's a great question. Actually, we do have the IMWG, International Myeloma Working Group, has set definitions for these. So they, so especially when we do clinical trials, right? We have to have set like definitions for this to make sure that patients are uniformly defined and all that. So we do have, definitions that are in place. But in the clinical setting, I can tell you in clinic, when, for example, if I have a patient who's got daratumumab or rituximab, the CD38 monoclonal antibody, right? Once they relapse, and it's just relapse. It's like, but I don't really follow the strict progression free. Like there is a definition for how to define a disease progression and lines of therapy also. That actually the IMWG has defined all that. So, but in the clinic, it's up to the investigator, right? When we see the patient, we're seeing the light chain is trending up. You don't wait till about for it to be more than 100 or the serum M to be more than 0.5. So that's the definition. The serum M has to be more than 0.5 for us to call disease progression. But when we see our patients in the clinic, like if we see a trend whereby it's going up, this is a high risk patient, I don't wait till 0.5. But for clinical trials, we have to. When a patient's on a trial, these are defined per the trial. So just to maintain uniformity. So I hope it answered your question. I'll be happy to send you the...
Duration wise, after how much time of the duration that if the patient fails, I'm looking for that after how much duration of that we can just label the patient as a refractory or sort of like that.
So it's not duration alone; it's also the response to therapies. So I can tell you in a pure clinical trial setting. Let's say the patient is on teclistamab, right, on a trial. So there are definitions for disease progression. So we can't call disease progression till the serum M, for example, has to be 0.5 or above, or the patient should have evidence of new, PET active lesions or what. So there are criteria. So let's say the serum M is 0.4. I can't call it as disease progression. So it has to be 0.5 and above. So I hope it answered your question. It's not the duration. There is a criteria, and there is, but I'm happy to send you the paper that defined, this the response. And they're actually updating it. We do anticipate that later this year we will have an updated response evaluation for patients with myeloma, because we're going to incorporate MRD responses and functional cure and all that. So,
thank you. Yeah. Can we have the email ID of yours? Mail ID?
Email ID, yes. I will send you. Don't worry.
Okay. Thank you.
Thank you. Before we go to Dr. Nikhil, I have one more question. Any comment on CMV, cytomegalovirus?
So that's a good question, Dr. Agarwal. So when we started doing bispecifics as such, we were not checking for a CMV or adeno or whatever, EBV routinely, right? But then we've learned the hard way that maybe we should check CMV routinely. So we didn't recommend that CMV should be routinely, checked for our patients who are on bispecific antibody therapy. But I can tell you that what we've seen in the clinic is we do see CMV reactivation, but end organ damage is rare. But then we have all this reactivation. What do we do about it? But nowadays, I know that nowadays in my clinic, I've changed my practice whereby everybody gets baseline viral assessment, and we check it every 3 months. The reason is that I've had a patient who was treated on one of the bispecific antibody clinical trials. So she's an older lady, 65 or 67 years old. So she's been in remission, like complete MRD negative remission for at least 2 years, right? And then she had, we never checked viruses for her because she didn't have anything going on. And then one fine day, she presented with a lymph node in her neck, right? And I said, this might be an infection. But then we got a scan. It was actually a lymph node, which we ended up biopsying, and it ended up being EBV associated diffuse large B-cell lymphoma, and which was actually resistant to chemotherapy. She had to get CAR T-cell therapy for EBV associated, lymphoma. And since then, I've actually like so humbling experience, right? So since then we've had a very low threshold. So I check it routinely at baseline every 3 months on our patients. And if there is cytopenia that I cannot explain, I have a low threshold. And if there is end organ damage, obviously, like if we have esophagitis or hepatitis, we always check for it. We've always done that. Retinitis, we've had CMV retinitis with BCMA CAR, but I've not seen it with bispecifics yet. So.
Thank you so much. Nikhil, go ahead.
Again, excellent talk, Dr. Meera. You covered the topic so well, and you always keep us updated with what's going on in the field. I have a couple of questions. My first question is, in patients with a high disease burden, whether it is high bone marrow plasma cell percentage or extramedullary disease, what is your debulking strategy prior to starting bispecifics?
Thank you, Nikhil, and it was good to see you again. So what we typically do is, so the idea of, giving bispecific to a patient is that it's readily available in the clinic, right? For example, if I see a patient Monday in the clinic, I could, I obviously have to get insurance approval. We are not like you, or we have to go through these loops where we have to get all this insurance approval for these expensive treatments, right? So once I have insurance approval, I could start the patient like midweek, Wednesday, Thursday, So what I typically do is, I've not, so if there are, like, for example, if it is a lesion that is at risk, for example, if there's a spinal cord, like if there's a spinal lesion, which I'm worried about, can have pseudo progression in spinal cord compression, I would radiate it, but I would radiate it along with bispecifics. But then I typically haven't used like another chemotherapy before bispecific antibody therapy, although there is some data that if you can use Cytoxan, it will help the T cell, because we know that when we use bispecific antibody in the setting of high tumor burden, your T cells are not as fit, right? So that was one idea of doing Cytoxan or sometimes debulking before the bispecific. But from what I like, when a patient needs therapy, there's a lot of tumor burden, I just start treatment, and I have a low threshold for TOSI. So those are patients that with the first fever, I'll do TOSI. That's pretty much, that's what I do. So, but that's the active area of investigation. What are we going to, is radiation going to help? We've seen some data where if you radiate and do CAR T cell therapy, there might be a little bit more response. I mean, this is very early results but we have good rationale for using that approach. The idea here is to help stimulate the T cells.
So we have had a few patients with extensive extramedullary disease. Couple of them we tried to debulk with different treatments like DCEP, and they could not make it to bispecifics.
Exactly.
And couple of them did get to bispecific, but they did not really do well on them. So in patients with such a huge disease burden, especially extensive extramedullary disease, do you think we can give bispecifics upfront without giving a debulking? Because we are always worried with a debulking strategy, risk of T cell exhaustion, and they may not really get to bispecifics as such.
Yeah, exactly. That is what we do actually. So if I have a patient who needs emergent treatment, I just start treatment, because like you said, the patient will not make it if we were to play around with other treatment, right? So the other things that I've done also, for example, I've had patients who had extensive disease, right? We start a bispecific antibody because that is the best option at that, that we have at that point. And then at some point, I want to do a CAR T, right? So what I've done is I've done bispecific antibody therapy. They get into a complete remission, and then I give them a treatment break. And I've also done stem cell boost. This is obviously off. I don't want you to quote me, but we've done a stem cell boost whereby I'll do a stem cell boost with some Cytoxan or whatever as Cytoxan followed by a stem cell. It's not really a transplant, but then a boost. And then once the patient's count recover, I've collected for CAR T and and proceeded as such. And also I've done let's say that a patient is on a bispecific antibody, and when they relapse, some of the relapses are really nasty relapses. They have extramedullary disease, sometimes secondary plasma cell leukemia. So in those patients also I've done the similar approach, VD pace or a modified VD pace followed by a stem cell boost. And when the counts recover, I try to collect the CAR T, because otherwise it's very difficult. Once they are on bispecific, it's nearly impossible to collect for CAR T right away, right off the back.
That's a great strategy. My second question is, some of the patients do really well with bispecifics and achieve a stringent CR or sometimes even an MRD negative state after 3 or 4 cycles. So in those patients, can we switch to a once in fortnightly or a once monthly regimen quickly without really waiting for 6 months or more?
Yeah, that's what we do in the clinic. Actually, what I do is in patients who are attaining a complete response, and sometimes I check for a bone marrow and look for clonoSEC and MRD, but that's not something I do routinely. So I just switch to once a month dosing, but you don't want to do it so early. Apparently, I showed you some, I had shown some data on a finite duration bispecific, right? So the median time on therapy was about 7 months. So because of the study, and this is the only study out there, right? So we kind of want to keep them on a more rigorous schedule for at least 6 months if we can. I mean, obviously, if they have infection, you have to back off. Otherwise, the patient, we lose the patient. So it's just a matter of. But if I were to choose, I will try to push till about 6 months or so, and then I'll make it less frequent, once a month. I've also done every other month dosing too. Especially with talquetamab, I find it very difficult to do talquetamab once a month because of toxicities,
So if a patient is on weekly teclistamab, what is the earliest that you would switch to, let's say, once in 15 days dosage and once a month dosage?
I actually go after the first couple of months.
Oh.
So I'll do, again, this is off the chart. So we'll do weekly for the first 2 months, and then I go to every other week with teclistamab. And then after 6 months, I just do once, like daratumab, pretty much like daratumab. This is what we do for this. It's the same schedule as daratumab. With talquetamab, I always do every other week.
Just one more question. We have all our patients are on monthly IVIG prophylaxis, and sometimes, in spite of them, they get recurrent infection.
Yes.
So, do you think a more frequent IVIG administration, let's say once in 15 days or once in 3 weeks, would really help these patients?
So, Nikhil, if I showed you that curves where, despite IVIG prophylaxis, there isn't a plateau. There is still ongoing risk of infection. So, what I typically do is less frequent dosing of teclistamab, which you're already doing, right? Along with that, I make sure that the periods of neutropenia are brief. That's something that we have a very low threshold to giving growth factors. And then the other thing is you have to see how the IgG levels are. I mean, anywhere between 600 to 800 is what I think. Again, this is not based on data, right? This is based upon how the patients do. So we know that here in the winter, we have all kinds of infections going on, RSV and COVID and all. So in that period, I try to keep it 600 to 800. In the summer, I'm more liberal. Tell them, okay, you can do 400, above 400, 500 is fine, But so I just cater to the city. We really don't know that. And actually, this is something that needs to be investigated prospectively,
So you target a level of around 600 to 800.
Sometimes 600 to 800 in the winter. The summer, I'm fine. But there are certain patients we have to keep 600 to 800 throughout,
Thank you so much. Again, it was wonderful listening to you. Thank you.
Thank you.
Nikhil. Before we go to Dr. Gopinathan, I have 2 questions related to IV gamma globulin. One of them is that these patients have renal impairment. Their eGFR can be sometimes 20, 30, 40. In general, we are always concerned about giving IV gamma globulin to a patient who's going to compromise renal function. And here we are going to give it repeatedly for a long time in a prophylactic setting virtually. So does this concern you anytime what the renal function situation is?
We've not done any dose modifications as such. I know that's a concern about worsening renal function, but we've not seen that too much in the in the clinic. So I don't make any dose modifications as such for IVIG.
A big issue. Okay. And second is, how early do you start this? Because you're not going with IgG level. So is it with the word go? The moment you start.
We have to get insurance approval, right? So what we do is when I see the patient in the clinic, when I put in for bispecific, I also make a staff put in for IVIG approval. I mean, IVIG was I think it's like $30,000 for a year. So it's not that much compared to bispecific, which is more than $500,000, right? So for a year of therapy. So it's not too much, but we've had issues with insurance approval and all. That's another different issue. But anyways, so what I try to do is I'll start with cycle 2, because cycle 1, the patients are still, they will have CRS or, they'll have, I just don't want to start two new treatments at the same time. So I'll do cycle 2, usually,
Fair enough. Do you ever give TOSI prophylactically? Just
I mean, so our program does not we can do outpatient TOSI. That is also not something that every place in the US can do it, because the way we get reimbursed is a little different. You don't do a lot of treatment outpatient. Certain things can only be done in, but we can do TOSI outpatient. But our program has not really. Our strategy is to use TOSI when needed, just similar to what we do with CAR, right? We use at the first sign of CRS, we do TOSI. That's what we don't use it prophylactic. But however, the NCCN guidelines now have adopted prophylactic TOSI. So we could use TOSI, but we have not done it.
And if you're doing it prophylactic, you will give it for till you reach the full dose. That means 3 doses.
And actually, what the Emory group has been doing is they do TOSI 4 hours before the first step-up dosing. That's it. Yeah. The other drawback about TOSI is that in all these studies, right, the use of prophylactic TOSI reduces the incidence of low-grade CRS. So it's like grade 1 C. I mean, so you also have to think, you're giving TOSI, and these are also expensive treatment, right? TOSI is also expensive. So you're giving it to our patients, and really you're only improving on grade 1, low grade, right? So that is one thing that I keep in mind. And then we've also some data that shows that use of TOSI, this is something that we presented at ASH last year, use of TOSI was also associated with increased risk of infection. So I'm like, I try to balance these things. So if I can avoid TOSI in some patients, I'll do it. But obviously if a patient has high tumor burden, I'm anticipating this is an older patient, I'm worried about CRS, I will have a low threshold, but I only do it when there is CRS. I don't do it before.
When you say it prevents grade 1 or 2 only, that means it doesn't sort of prevent grade 3, 4
Yes.
at 1, 2.
Yes, that's what the data says. The majority is grade 1. It actually is grade 1 that I don't know if I've shown that data, but it's maybe the slide had some data like the box plots, but it's usually predominantly it is a low grade CRS that you improve on. Similar to CAR, it's when you do TOSI prophylactically, you improve on low grade CRS.
Dr. Gopinathan, go ahead. Sorry.
I think I was just, it was very a lovely talk, ma'am. I was just hearing all the concepts, and it was, my 2 things attracted me. First is the stem cell boost strategy that you are telling for all the opportunistic viral infections. So I was just wondering, like, just to start with, I had one similar patient in the last 2 months back. This guy, after the 6th dose, he developed profuse large volume diarrhea. He had a skin rash, and he became encephalopathic. So initially I was thinking this encephalopathy, or whether it was like kind of an ICANS or something, but this large volume diarrhea and the skin rash was, and then when I sent the CMV copies, it came to almost 5,600. So ultimately he was lost to basically a CMV disease. So in these kind of heavily pre-treated patients, whether you have problems with mobilization, how do you mobilize the stem cell, and what is the dose that you use for stem cell boost is what I wanted to ask you.
Thank you. That's a great question. So, our practice is a little different. So when we see our patients like newly diagnosed myeloma, right? So we try to collect for 1 to 2 transplant. Let me just say 1 transplant and a boost, or a 2 transplant. That's what we do nowadays. So we already have, we're very fortunate in the sense that we see our patients throughout, right? So if a myeloma patient from diagnosis, we see our patients throughout. So it could be like 15, 16 years of follow-up with us, right? So these are patients long-term, well-established, and they have stem cells with us in storage. So I can do all that because fortunately, this was collected years ago, right? So everybody who so patients get an upfront transplant, use whatever 2 to 3 million for like a MEL200 transplant. Whatever is left over is here in storage. So so that's why I can do this. So it's not something that I don't think we can collect. Like, for example, in your patient, that's not the right time to collect. You'll not be able to collect, right? And you also wonder, what are you collecting, right? I mean, it's not possible. So if you have stem cells in storage, we can do what I just discussed, right? But otherwise, I don't think it is feasible.
I think maybe we have patients landing up to us at that point of time when they are multiply relapsed refractory, and then only they land up to us. I think maybe that strategy made. And one more thing, the second point which was interesting to me is the combination of bispecifics plus some kind of cytoreductive agent like Tecli plus cyclophosphamide or Tecli plus Benda in these kind of extramedullary disease. Is that a strategy that is being looked upon for all this extramedullary disease?
So there is some preclinical data. I think it was recently like they had this. It's preclinical data. It's not like a clinical trial or anything, where they found that by using like cytoxin, it's mainly cytoxin, right? You can help that cytoxin helps T cells as such. Like it helps reduce Tregs and possibly reinvigorate the T cell as such, right? So that is the idea. So it's not given simultaneously. Like in that particular preclinical study, they did cytoxin early, and then following which you did a bispecific. The patients got a bispecific, or I think it was whatever animal model. It's not a clinical trial for sure, but so they found that the T cell function was much better when there was cytoxin given before bispecifics. So that's the idea. I don't think you can combine. It'll be too toxic to combine things. I mean, you could try a low dose and see, but I wouldn't do it because as such, I think, I mean, these are effective therapy, right? And if I have to really like debulk it, I'll just radiate. That's what I would do, because the combination works well. Cytoxin with bispecifics can sometimes be challenging because most of these patients are already lymphopenic, neutropenic, or they have like borderline neutrophil counts already, right? I don't want to do anything that, sets our patients back, right? Yeah. I hope it answered your question.
Yes, ma'am. Yeah. And I think prophylactic TOSI also, I think since if majority of the CRS are going to be grade 1 or grade 2, I think it's better to reserve maybe for grade 3 to combat infections.
Yeah. And I know in this country, prophylactic TOSI has taken, that's been accepted as one of the approaches, mainly because we can do step up as an outpatient. Right? That is the style. Like that is really the reason. But if you all are doing it inpatient, I mean, it's fine. The idea here is that like when we admit our patients for step up dosing, right? The median hospital stay is 10 days. So 10 days in the hospital, imagine, it's not good for the patients. It's not good for the hospital. It's very expensive, right? So that is why we are trying to come up with other strategies. Even similar for CAR, like all of our CARs outpatient, we don't like, we just do TOSI at the first CRS. And as long as there is reliable, caregiver support, I think that is reasonable. And then the patient should stay close to the hospital. So what we do for our CAR patients is that we, obviously the CAR T program, like Idacel and Cilta-cel, that's BMS and Janssen, they do have a program whereby they actually provide housing. They will pay for housing for our patients. So they could stay, close to the hospital within 10 minutes actually to the hospital. So in that way, they can come and see us. We are here 24/7. We have a 24-hour clinic. So, and which is staffed by, our MDs. So what will happen is when they have a fever, they call us and they can come and see us any time of the day. It's like a clinic. So we'll talk to them. We'll make an appointment. They come in and they are seen actually within 1 hour of CRS. Or probably less than 1 hour of CRS, So if you have an approach like that, that might work. But otherwise, steroids are not a bad option too. I'm thinking like you've seen, there was a recent publication and steroids are cheap, they're effective. So I think I'll do like Dex with the first fever is also fine. It's a reasonable option,
Thank you, ma'am. Thanks a lot.
Thank you.
Thank you, Dr. Gopinathan. Again, before going to Dr. Hita, one more question. How often you use anakinra?
I've not used it for bispecific. With CARs, I have, Dr. Raval, yeah.
Yes, and it is very rare. Do you use prophylactic anti-epileptics?
Not for bispecific. For CARs, we do.
Okay.
Everybody's on Keppra, yeah.
Dr. Hita, go ahead.
Thank you, Dr. Meera, for that very clear update. Ma'am, I have one question. Like, how do you assess the response? How early you start the response assessment while on the bispecific, and how often do you repeat the SIFT and the bone marrow? And do you give a treatment-free remission once they achieve? So, is there any option of stopping the drug for some time?
So that's a good question. So, so what we do is, we typically when the patients are on bispecifics, I check. I don't repeat bone marrows. I don't repeat bone marrows unless they're on a clinical trial. I don't repeat bone marrows. So I'll check the SPEP and serum light chain. I'll do that sometimes every month or sometimes every every other month. So that's some of our patients are already heavily pre-treated, right? So, and they have aggressive disease. So I don't want to stretch it to every 3 months. So it's either every month when they come in for their treatment or every other month. So that's typically what I do. And I've also shown some data on limited duration bispecific. So we know that we know that certain subset of patients, so in our series, 10% of our patients did well with just like 6 months of treatment, and they were in remission for some time. Like some of our, I think one of the patients that I think I have been in remission for 4 years of therapy. So she got bispecific antibody therapy. She developed an Aspergillus infection while she was on a bispecific antibody therapy. I stopped all therapy. She still is on IVIG even to date, but she's been in remission without any treatment for 4 years. So you see patients like that. So what we have identified is that patients with low risk disease, this is a good strategy. You can give 6 months or so and then watch them off therapy and see, but then you have to watch them very closely, right? That's one. And then patients who don't have extramedullary, so it's like pretty much low risk disease, and that's really what we have seen. We really don't know who are the patients. We don't know about all about that patient's population who can be treated with a finite duration, but we think that this is a good strategy, especially when patients do not have high risk disease. But I would not stop early. I would do at least 6 months, and then we can modify it.
Thank you, Dr. Hita. Again, before we go to Dr. Sandeep, 2 more questions for you. One is related to delayed neurotoxicity that you see with CAR-T. Do you see with bispecific?
I've not seen delayed toxicities with bispecific. So if there is a CNS problem, it's something else. It has to. So the first thing will be to rule out infection, or disease relapse or whatever. It's very rarely delayed ICANS. It's very rare.
How common is HLH?
HLH, so in our collective experience, we've had 1 patient who developed HLH. So it's not very common. So, yeah.
Dr. Sandeep, your question.
Yeah, thank you, sir, and for the opportunity and nice presentation, Dr. Meera. I have 2 questions. One is, what is your experience with cytopenias when you're using bispecifics? I mean, we have seen patients who have prolonged cytopenias, and the weekly cycles in the first cycle, especially cycle 1, the weekly dosing does get delayed. Then the second question which they ask us is, we're getting a costly treatment and the delayed thing. So a bit of difficulty in counseling. What's your take? What's your experience on that cytopenias?
Yeah, thank you. That's a great question. So, as you said rightly, cytopenias are more common in the first month or so. So what we have done is, so if I have a patient, I mean, the patient that we typically start on bispecific are patients who have a lot of disease burden, who cannot wait, right? Otherwise, I would have chose a CAR, right? So what I do typically is, if they're cytopenic, I have a low threshold for growth factor. I know there is a very minimal risk of, making CRS worse, especially when you do it in the first, but we have not seen that. So if I have a patient who is cytopenia, sometimes the cytopenia can be due to disease. So if that is the case, I really have a low threshold. I'll do Neupogen and bispecifics. The other important thing is, when you have cytopenias later, it's important to rule out other cancers like MDS or whatever in the bone marrow, or also viral reactivation syndromes like CMV, adeno, and all that. This is very important that we rule out that. But I have a low threshold. I typically don't. If a patient needs therapy, like for example, they just started treatment, there's full of myeloma, I don't hold treatment. I give bispecific. I will proceed with bispecific along with the growth factor, like Neupogen or whatever. But if somebody is in remission, that tells us probably then you might have to cut down on the frequency of dosing. And in those patients, I sometimes hold treatment. I'll do, like, if they are already on a weekly schedule, I might go to every other weekly schedule, or they're on every other weekly schedule, I go to once a month, something like that. But early on, I don't hold treatment. Neupogen, bispecifics.
Okay. Okay. And then once a patient achieves MRD negativity, I mean, in your experience, when do you consider taking off? Like, do you consider taking off, and when do you consider at the earliest taking off? Because that's the second most common question with people ask, like, till
Right.
when? That's the question. Yeah.
Right. So typically when I see the patients in the clinic, I'll tell them that all myeloma therapy is long-term therapy. So our patients are primed to it, right? So, but then let's say the patient has attained MRD negative CR, right? If they don't have issues, they are doing well, I will continue once a month, right? But if there are patients who have had issues, there are patients who cannot come. It's too much for them to come once a month. There are older adults with myeloma who are frail and it's too much for them, or they have side effects, multiple infections affecting their quality of life. Then I might take them off, because I've shown some data where in a subset of patients, all they need is a limited duration therapy. So I'll be careful. If you are taking people off therapy, you will still probably want to continue IVIG, and then you probably want to monitor these levels, the myeloma panel, at least every 4 to 8 months. That is every month or every other month. You want to keep a very close eye. And if they have any symptoms, you want to get a scan, because we've seen that just similar to CAR T-cell therapy, a third of our patients, when they relapse, they will have normal SPEP and serum light chain. It's all on the PET scan or a CT, so you want to maintain that high level of clinical intuition, because you never know, these are very, very extremely heavily pretreated patient population, right? So.
Thank you, sir. Thank you, Dr. Meera.
Thank you. Again, before we go to Dr. Sushma, do you think in India we will be concerned about tuberculosis?
I would think so. I mean, I know that it's so prevalent out there. So, so when we wrote this ASCO editorial, right, we did comment on tuberculosis as such. So I think what we suggested was, I mean, you know more about tuberculosis than I do. I've not even seen a tuberculosis cases in 15 years or so. So, some level of imaging might be important, right? I mean, what are your thoughts, Dr. Agarwal? I think probably it's better to hear from you than I said.
Long back, we used to give Isonex prophylaxis, but that is obsolete. So now we just have a high index of suspicion. Anybody who has got a long-lasting symptom related to that, then we go all out with X-ray, HRCT, bronchoscopy. No more empiric therapy, no more prophylaxis. That's what we do in general medicine. I suppose same will apply here. But yes, this could be a problem.
I have had a MAC in reactivation. A MAC. One patient, that's it.
Holistic infections. And from that, I wanted to ask you about this diarrhea. Do you look out for Clostridia difficile very commonly?
Yeah. Every patient who is on one of our therapies, because what I've learned over the course of the last few years is that our patients who are getting bispecifics, they're it's like having HIV/AIDS, pretty much, because you have no counts, you have no immunoglobulin levels, your neutrophil count is gone, lymphocyte count is gone. So you have to be very, very careful. You never know what infections they come up with, right? So, it's. I mean, these are not benign drugs, is what I meant to say.
Infection is the lethal issue.
Even here it is. I can only imagine how it is there, which is a serious problem there than it is here, right? So
Johnson is bringing talquetamab also very quickly. In a month or two, we are going to get that. So you recommend that with our infection incidence and prevalence, we should prefer that in front of as the first choice?
I mean, probably. I mean, the problem also with talquetamab, it's not an easy drug to take. I can tell you that nearly 70% of our patients, they will have, dysgeusia. They can lose up 5 to 8% of their body weight. So, so it is difficult, it's challenging. And I've not had a single patient who can take talquetamab every other week. So after a month, the patients are they can't do that anymore because they can't eat, they've lost weight, the nails are peeling off, skin is peeling off.
Indian patients with this skin problem and the mouth problem, they will just not take it.
I know, even here it is difficult, so I can only imagine. So it's hard to choose between. I think if a BCMA antibody drug conjugate Blenrep or belantamab gets approved, I think that that has corneal toxicity, but it might be better tolerated. I don't know. I mean, especially in your kind of setting where you have all this, moving pieces. So.
Yeah, Dr. Sushma, please go ahead. And sorry for keeping you waiting.
No problem, sir. Excellent talk, ma'am, and got to learn so many new things. I have few questions. When MB Agarwal sir asked you about CMV monitoring, do you do it 3 monthly, right?
So that's something that Dr. Sushma, we've learned over time. It's really not set in, it's not really a strong guidelines, or it's not really set in stone. But then what we have seen from the data is that patients do have CMV reactivation, but end organ damage is rare. But then since we're still learning about what exactly is the CMV reactivation, or what exactly is a clinically relevant viral reactivation in this setting, right? So because of that, we've just recently adopted, in the guidelines, we don't even recommend doing CMV checking routinely. But now we've learned, and from a collective experience, we are now rethinking this. Should we check CMV once, and just like what we do for our allogenic transplant patients, right? We do check them at baseline. We do check them every few months or so. So I'm increasingly adopting that in my clinic, especially because of some of the side effects that I've seen. In fact, I've also had CMV reactivation with BCMA CAR too. So I've had a CMV reactivation with retinitis, and patient is viremic for, I think, 9 months now, still viremic. So because of all this, we're being extra cautious. Not that I would not do anything different. There is CMV reactivation. I'll keep a very close eye. I'm not going to hold therapy, and we don't treat CMV viremia as such, right? So unless they're obviously trending up and all that, but it's, just being very cautious. And again, we are still learning. We don't really know everything about this.
And ma'am, we don't preemptively start them on treatment at the particular level of copies? No.
So that's, that's an important question too, right? So I don't really know if we have to adopt something like what we do for an allogenic transplant, where there is, if it is doubling time, right? That's more important, right? We really don't know that. And the other thing is also, these patients are on IVIG. That will also help a little bit, right? So I don't have a good answer for that, but I've not treated our patients. So let's say that I have a patient who has CMV reactivation, low level viremia. I'll keep following these numbers. I'll put them on IVIG. If the patient is in a very good remission, I might lower the frequency of bispecifics. These are things that I do, but I don't treat it. I have not treated it yet. But I'll have a low threshold. Like, for example, if the liver enzymes are going up, then I'll make sure that I work this up, make sure it's not CMV, hepatitis or whatever, or if the patient has diarrhea, I'll make sure that they have a full workup, they'll get a biopsy with CMV stains and all that, making sure that I'm not missing anything, right? So that's what I typically do, have a low threshold. We've also seen esophagitis, like adenovirus, and I think CMV too. So we've seen that too. So have a low threshold is what I would do, but I won't treat just pure viremia.
And my second question is, you talked about resistance. So in your experience, have you come across any primary refractory case to these bispecifics?
Yes, yeah. So in the clinical trials, we know that anywhere between 15 to 20%, maybe even a little bit 25% of patients are primary refractory. And it's because of the T cell exhaustion. So let's say that we have a patient now who comes in for bispecifics. The bispecific antibody therapy failed, right? So they got treatment, they didn't have a response. But I'm not giving up there. But what I would do is I'll switch treatment. So I've had patients where I'll switch treatment, and maybe later I might have done like a stem cell boost or something, and then I'll re-challenge bispecific again, because the most common reason for refractoriness to bispecific antibody therapy is a T cell dysfunction. It's not antigen loss. It's not, it is T cell dysfunction. So if there is any way we can improve the T cell fitness, I'll re-challenge it. Because at the end of the day, there is, just like we re-challenge, and sometimes I've also started bispecific with other, like, for example, when I re-challenge it, I might do IMiD, like lenalidomide or pomalidomide, or even a little bit of daratumumab. If we can, I'll do that in combination with teclistamab. I've not done that with talquetamab, but with teclistamab, I've done that too. But this is all off-label, and please don't quote me on that. Yeah.
And ma'am, when do you start worrying about it? After like how many, when are you really?
Oh, the first month you will notice, like, the patients, if they respond, the median time to response is about 1.1 to 1.5 months. So if they don't have a response in about a couple of months, there's no point, you can take them off,
And usually my third question is, this bispecifics we usually keep it for penta-refractory cases. Is there any particular subset of patients where you like to introduce it little earlier? Like, is there any subset of patients from your experience whom you feel that maybe switching from BOT to, Carfil, I don't know. I mean, you try to put it in third line, the T cell engages?
So the thing is, currently when we give a drug here, right, we can only use it like per the label, right? Per the FDA approved label. So it is approved for use in the 5th line. It doesn't have to be penta-refractory. They have to be exposed to they have to have triple class refractory disease. So they have to have immunomodulatory agent, CD38 monoclonal antibody and proteasome inhibitor refractory disease. That's so. But then up to a point, this is being investigated in the earlier lines, right? For example, we have clinical trials. One of the Majestic-1 clinical trial is investigating teclistamab in patients who are newly diagnosed. So they're using it in combination with daratumumab and Revlimid and and Velcade actually. So we have it used in combination. We have seen very good results, like 100% MRD negative, like not MRD negative, 100% complete CRs. We've not seen that kind of CRs with any other treatment, right? It's 100%, and the side effect profile is very favorable. So I do anticipate that in the years to come, this will move early. There's also another clinical trial. I think the first results were reported at ASH, where they are actually post-transplant. They're evaluating teclistamab along with lenalidomide in the maintenance setting. So we will have that too. So, so this is going to be something that we'll be using earlier, and then we'll be using it with other myeloma drugs. Hopefully, I mean, that's the idea. Everything starts in the 5th line, and once we have some data, it'll be investigated in the earlier line. So I do anticipate it going up.
Thank you. Thank you so much, ma'am. Thank you.
Thank you.
So, Dr. Meera, teclistamab is used most commonly as the first bispecific. It's only because of the way it has come first, therefore, or the others are not so good.
So one of the reasons, Dr. Agarwal, like you pointed out, it's a first in class, right? So that's why I can tell you the reason why I used teclistamab. If I have to choose a bispecific, BCMA bispecific, I use teclistamab over elranatamab because of the cost too. I mean, again, this is off label. So we did a little bit of cost effective analysis. This is not published or anything, but teclistamab was more cost effective than elranatamab. So that is one reason why I personally choose teclistamab, not because of any conflicts, but then this is, but we'll have more bispecifics, BCMA bispecifics coming out. So linvoseltamab, that will be approved in the summer of this year. The only reason I would use that is because you can give it at every 4-weekly dosing. Because if I do every 4-weekly dosing teclistamab, I know that I'm not following, it's off label. So I'm not sure if I'm compromising on efficacy. I am sure there is some loss of efficacy also. We don't know that, right? With the linvoseltamab, I can go up to 0, every 4-weekly dosing. So that might be, but I don't know the cost of it. So, I'm trying to be more cautious about cost, and, the burden on healthcare resources here is too much. Myeloma is the most expensive cancer to treat. So I think as myeloma physicians, it's important that we also choose cost-effective treatment, right? So.
Your index of doing neuroimaging and CSF examination is also, you preempt very oftenly you do that, or very carefully? If you have neurological symptoms, are you very liberal with doing neuroimaging and CSF examination?
So in patients with ICANS, right? So they always, so when we see our patients for bispecific antibody therapy, they always get an I-score. They get an I-score on day 1. Throughout, they get I-score. Every day, the nurse will ask them the I-score. So we have I-scores every day. So for bispecifics, I actually, if there is evidence of ICANS, I just treat ICANS. I don't really do neuroimaging, not for bispecific. But for CAR, obviously, we want to make sure that we, get an MRI. I do get CSF, not because I'm suspecting anything in the CSF, because then I can also do intrathecal methotrexate for CAR-associated ICANS. If it is steroid refractory, I do that. But rarely we find new evidence of CNS disease. But you never know, with these, with bispecifics, if there is a neurological symptom later out of the ICANS window, I would do a CSF and imaging, mainly because to rule out infections or disease relapse. That's really why we do it. But we've used intrathecal, methotrexate. Sometimes we use intrathecal methotrexate and steroids and cytarabine for our patients who have ICANS, steroid refractory ICANS to CAR-T. even I have a low threshold. If they have ICANS, even if they're on steroids, I try to do intrathecal, then I can cut down on the systemic steroids when they get CAR-T, right? So, but not with bispecific. We've not had that with bispecifics. So,
thank you. Dr. Nitya? Are you there, Dr. Nitya? Okay, Nikhil?
Without taking up too much time, I have a quick question. So we have a patient on teclistamab with talquetamab as part of a clinical trial. Post cycle 1 day 15 dose, patient has developed severe vertigo, unexplained hypertension. Patient has no prior history of hypertension, not a diabetic, not a hypertensive, severe hypertension, unexplained vertigo, not really subsiding with the usual symptomatic treatment. So I just wanted to know, do you have a similar experience when you have used these drugs in combination?
so talquetamab, as you might know, it's associated with cerebral toxicity, right? Are you sure it's not ataxia or, so I would be careful. We've had patients, I've had at least one patient I could think of who've had talquetamab and have neurological, issues like balance issues and all that. So if it was my patient, I would stop talquetamab. If the clinical trial allows you to do it, stop it and see how the symptoms get better, right? So I'll be worried about, this is actually the package insert for talquetamab now gives you a warning that there is concerns for cerebral toxicity. There's one patient in the monumental study who developed ataxia, one patient. So less common than the GPRC5D CAR-T, but it's of concern,
I think that's helpful. So we'll look at it.
Thank you.
Having said that, patient main symptoms were quite suggestive of a BPPV, belong paroxysmal positional vertigo. It was mostly episodic and positional, and the hypertension also remained unexplained. So we could not find anything in literature that links either of these drugs to a new onset.
And MRI was okay, right? It's not like if we are missing any press, like nothing of that sort, right?
Nothing. The MRI imaging is fine.
Okay. And if the patient is in remission, you could consider giving a treatment break, a 1 month of break and see, right? They're okay. 1 month of break.
Just a cycle 1 day. 15.
But they respond really fast. So I'm sure if they...
Okay.
Yeah, so that is something to consider too, because if you're using, even with one drug, the median time to response is about a month. So with 2 drugs, you will likely see that if you were to repeat the light chain, you will see those numbers of probably he or she might be in remission, so you can take off and then go back again, right? And introduce 1 by 1 or something like, the clinical trials sometimes don't let you do that, but it all depends on the protocol. So, yeah.
Thank you so much.
Thank you.
Thank you. We have no questions from anybody else. Nitya, are you there?
Yes, sir. I just lost my internet connection for a while. I just have a couple of questions. I'm not a person who treats a lot of myeloma, but Dr. Meera, that was an amazing presentation, and it was a very big eye-opener for all of us who see a lot of relapsed refractory and multiple myeloma. I just have a basic question. You've been through CAR-T and bispecific. So are there any, how do you choose which patient goes? Of course, the disease burden is one. So how do you choose between the two? And do you think we should be having some markers to find out which patients would be refractory and try to find out whether to give them bispecifics or not? As you said, about 1/4 are going to be resistant. So that is one thing I wanted to ask. So probably...
Yeah, that's a good question. Okay, so at this point, what we do, let's say outside of a clinical trial, right? What I do is we have CAR-T cell therapy available for use in the 2nd line, right? Bispecific antibodies are available for use only in the 5th line. So what I do is if I have a patient who I see in the clinic, who needs a T cell therapy, who've already got CD38 monoclonal antibody-based therapy as disease relapse, I go with CAR-T first, mainly because it's available early. Really, it's very hard to compare one versus other, right? Because we have to remember that a patient who gets a CAR-T cell therapy are patients who can wait, right? Who have disease that can wait 4 to 6 weeks. Those are the patients who are treated with CAR-T cell therapy on a clinical trial, right? So when you look at this data on, clinical trial data from CAR-T, it's impressive, obviously, but you have to keep in mind, these are patients where the tempo of disease relapse is a little different. With bispecifics, we know that these are not typically, clinically when we see a patient, right, our intuition is if we have to treat this patient right away, we choose a bispecific because we know that this is not a patient who can wait 4 to 6 weeks or 8 weeks or whatever, right? So that is something that I always keep in mind. The side effect profile is very different, right? With CAR, the non-relapse mortality with the BCMA bispecific is about 15%. 15% is like allogeneic CAR, transplant, right? So that's something we have to keep in mind. I think with bispecific, the non-relapse mortality is come down because it was mainly infections, right? With CAR T, we were already doing all the prophylaxis when we were doing clinical trials because we've already learned from the CD19 CAR, right? With BCMA CAR T, we were already giving them IVIG. They were already on, PGIP. So we've already had infection prophylaxis in place. And despite that, this is what we see. Despite that, with bispecific, we didn't know any of this. So there was really a learning curve, right? So I think to your point, the disease, resistance to both CAR and bispecific is very similar. It is T cell dysfunction. The only thing with bispecific antibody therapy is that we see that there is increasing loss of target antigen with bispecific compared to CAR T. Because with CAR T, biallelic antigen loss with BCMA CAR is about 5%. But then functional loss of antigen with BCMA bispecific is about 40%, 30 to 40%. That's what we know, at least from the data. So if I were to use bispecific first, then a BCMA CAR T might be difficult, because they would have lost the antigen. So I can't use it right away. So if I have to do bispecific early, I will wait, make sure that I give some other treatment in between. And sometimes I do this same, like a stem cell boost kind of approach just to help their T cells. And then I'll do CAR later. So in an ideal world, I would do CAR first. And, when the patient has disease relapse, I still try to do a washout period of some other therapy in between the T cell therapy, and then I'll do bispecific. So CAR followed by bispecifics if it's BCMA, and then I can use the same target, BCMA and BCMA. But then if it's already a patient who's got a BCMA bispecific, if I have to do CAR, I have to do a longer washout period. Sometimes I do a stem cell boost. Sometimes I've done BCMA bispecific followed by a GPRC5D bispecific, but then the responses might be like 30-40%, and I think PFS is 6-7 months, not great. So even in that setting, I think it's important that we do something for the T cells to, reinvigorate or whatever. I think the stem cell boost kind of approach comes in that. It's important for us mainly because we are going away from doing salvage transplant, right? So nowadays, we don't do transplants upfront for our patients who are 75 and above, because of the German data that just came out. So we don't do that. So then, and then we don't do salvage transplants at all. Again, because of the German data that showed that salvage transplant compared to lenalidomide and dexamethasone was it was the same outcome. So it's important because when we see our patients nowadays, if I see a newly diagnosed myeloma patient now, I need to make a decision on how much stem cells I have to collect for a patient, right? So I typically nowadays I collect for one stem cell transplant and a little bit more for a boost, because these are all expensive, procedure as such. Storing stem cells is space. It takes a lot of space. It's expensive for patients at the healthcare system as such. So that's why it's important for us to make these decisions. I hope. Thank you. I hope I was clear.
Yeah, that's nice. And it was very clear actually. And I think I got the answer that I was looking for. The other thing is on vaccinations. So many of our patients, I think this is going to be a perennial issue. So do you think that they need a resequencing of vaccination? And since many of them were on already immunosuppressive therapy, so how do you sequence them with a high volume of disease when you can't even wait for some time for the vaccinations to work? So how do you actually sequence, because it's important in hematology as such?
Of course, yeah. Like you rightly said, infection and pneumonia, right, is an important. So what we have done is we've updated the pneumococcal vaccine for I know the responses are not going to be good, right? I mean, the response to vaccine, I meant to say, it's not going to be great, but that's all we have. So what we do is we try to make sure that our patients are up to date with the pneumococcal vaccine if they're getting bispecific just before the bispecific if we can. And obviously everybody's on acyclovir or equivalent for herpes zoster prophylaxis, Bactrim and IVIG, right? And everybody gets their COVID and the flu, and now we have RSV available for our patients, right? So we update all that while on therapy. And I always tell our patients that, this is not going to be 100% effective. Even in people with who have myeloma in remission, and off therapy, they don't have a good response to vaccines as such, right? So, but we update all these vaccines for our patients on bispecific, and I always encourage them to wear a mask when they come to the hospital. They're okay going shopping without a mask, but then they come here to the hospital with the mask. I always tell them, you get everything from the hospital. You're safe, outside the hospital. So our patients are very, very vigilant as such. And then we also have a very, very low threshold to swabbing people, right? So if they call us for whatever, we make sure we arrange for a swab. Like we are very fortunate to have this multi-viral, panel viral testing here, right? So that's another thing. So we have the resources in place. Actually, I have a clinical trial that's going to go on soon, where we are checking for viral infection at baseline. So everybody who before starting therapy, they'll be getting a swab, because there's something more than, like, I really don't know. These might be patients who are harboring it and they get reactivated is what I think, but we'll see. These are like obviously preclinical ideas, but for CAR T cell therapy, 100 days post-CAR, just like transplant, not 100 days, actually 6 months post-CAR, we can revaccinate our patients, just like what we do for our auto transplant. But the main thing I stress is mainly the RSV and COVID and influenza. Influenza is probably the one that I stress all the time. I tell them, if you're in the influenza season, that is what somewhere between October to May, they should get a vaccine, because you tend to, we have so much COVID around even the summer that, and you're giving them IVIG, that'll give some protection against COVID too, right? So we're okay with COVID, I think. It's mainly the influenza. RSV as well, sometimes is, but that's a new vaccine that has just got approved for the last couple of years. So I really don't know, we don't have a lot of data on that in BCMA bispecifics or CARs,
So that was my third question, whether to regularly swab them and find out, because the viral panel is quite popular here also. So we just find out if patients are at risk and we put them on extra vigilance. So that, I think you've answered that.
But it's not proven or anything. So if I were to, I don't do it for my patients routinely. I go by the symptoms, but I do have a low threshold, even if they call with whatever, if they have an exposure, I do. But the thing is, let's say that if I catch it, right, early, but with influenza, we have Tamiflu we can do, right? I mean, but what else with other things? I really don't have much to offer, right? With COVID also, you could do something. You have Paxlovid or whatever, you could do that. But, so that's another thing. So when we order a test, I always think, the cost of it, and then what am I going to do afterwards, right? So that's why I'm very cautious. If it's on a clinical trial, the approach that I told you is on a clinical trial. So in a clinical trial, this is a good avenue to check all kind of approaches. So I think in 5 years from now, we will know the right approach. Yeah.
Probably, I think it would become a guideline by then. So,
yeah.
Thank you so much, Dr. Meera.
Thank you.
Just one last question to you, and we will let you go. Do you think autologous transplant is going to decrease with all this?
That's a good question, Dr. Agarwal. I think we've already seen drop in the incidence, the autologous transplant rates have gone down, at least in our center. I mean, we are a transplant heavy center, right? We used to do around 300, 350 transplants just for myeloma when I started here 5 years ago. And now it's gone down to around 200. So we already had a drop. So the reasons are, one, because now we use 4 drugs for all patients. Unless they're really frail older adults, we use it for all of our patients with newly diagnosed myeloma. So if we have so much good drugs, why put them to transplant, right? So and in patients above 75, because of the German data, I don't do a transplant. If they're 75 and above, because if I can't do MEL 200, you're not getting a transplant. Pretty much I tell them that, because that's the German data compared MEL 140 versus I think I can't remember what the other comparative arm was, but it pretty much what the takeaway message was that you are not doing much by giving them MEL 140. So, and I do give MEL 200 up to 75 because I don't have data supporting use of MEL 200 over 75. So my cutoff is 75 for, I've done somebody who's like on the verge of 76 with, but that's rare. And then we don't do salvage transplant at all. Because again, because of the recent data that study compared lenalidomide and dexamethasone to a salvage transplant, and there was no difference in outcomes. The curves are overlapping. So it was a 10-year follow-up on the study too. So that really tells me that salvage transplant is, it's gone away already. So, so I would do CAR or whatever, and as you know already, CARs are being investigated in the earlier lines, but it's going to be tough to beat transplant early, I think, so that's something that, but with time it will go away, I would think, like for MCL, like mantle cell lymphoma, right? Transplant is no longer a thing. That's also thanks to one of my colleagues who did this, he presented this data at the plenary session at ASH. So,
this CAR again, I have one more question. Do you think with all this long-term cytopenias and all, and second malignancy, you get a little discouraged in doing early CAR for your patient?
I mean, I do worry about side effects in early CARs too, but then I'm hoping that in time to come, right, we'll have better, like we already have another CAR called anito-cel, which is not as efficacious as cilta-cel. It's somewhere in the middle. It's not like ide-cel is our weaker CAR. I mean, I'm hoping this is not recorded, but ide-cel is one of our weaker CAR and cilta-cel is one of our stronger CAR. And then, but cilta-cel has a lot of side effects. Non-relapse mortality is at 15%. Ide-cel, it does not have a lot of side effects. The non-relapse mortality is 6%, but then it's not the best CAR we have. So somewhere in middle, we have a new product called anito-cel, which is going to be FDA approved soon. So I'm hoping that with time we will learn more, but it's not a curative treatment for myeloma, right? So we'll have to, patient selection is important. I think we still don't really know, who are those patients who are at a high risk of all these complications. To your point on cytopenias, I think we've seen cytopenias, late in the late lines, in the early lines. Now that I'm doing CAR in the second line, I don't see a lot of cytopenias as such. Yeah, so we got better at it, but obviously there is a risk of MDS and second cancer. I don't know if it's a CAR effect. True CAR-associated malignancy is rare, right? Like CAR-associated T-cell malignancy is very rare. It's mainly MDS and other cancers, because that's mainly because of other treatments the patients have got. I think we'll have to wait for the CARTITUDE 6 and CARTITUDE 5, which are trials in the newly diagnosed myeloma. That will tell us, how this is really panning out for patients in the newly diagnosed setting. But I'll be cautious. I don't believe that CAR is for everybody. I am not of that opinion that CAR is for everybody, but yeah.
Thank you, Dr. Meera. Almost more than 2 hours you are with us.
No worries,
Extremely
yeah.
grateful to you. It was very, very educative. I'm sure those who have been silent listeners, they must have learned a lot. Oh, suddenly some questions have come in the chat box. Do you want to answer?
Yes, sure.
Okay, Dr. Christopher has asked, can you share your approach to steroid tapering with progressive cycles of bites? How fast do you reduce the amount of steroids if the patient does well from the angle of CRS?
So that's a good question. So what I typically do is with teclistamab, we do 60 milligrams of dexamethasone on the, that's a pre-medication that we use every time they get the teclistamab dosing. So I actually cut down on the dose from 16 to 8 to 4, something like that in the second cycle. And I've taken patients off steroids entirely. We have no problems there. Only in the first month we have to be extra careful. After that, I would cut down, and steroid free is fine too.
Right. He has another question. Can you share your approach to? Okay, it's the same question. Okay. He has put the same question repeatedly. Dr. Raj has a question. If teclistamab is started due to urgency, can you give pneumococcal vaccine and optimum timing in relation to the treatment? I think you have answered that question already.
That's a tough, we don't know the optimal time. We just do what we can for our patients. And ultimately, disease control and takes precedence over everything else, right? So,
thank you, Dr. Meera.
Thank you.
A great session, wonderful session. Enjoyed each bit of it and very, very educative. You have been very helpful. This will help all.
You.
So, yeah.
Thank you so much, Doctor. I can email you the slides if anybody wants it, yeah?
Great. Thank you.
Thank you. Have a good night. Yeah, bye.